Good morning, everyone, and welcome to UNC Health Game Changers, where we will talk about COVID again today. My name is Leslie Nelson Bernier, and I have the privilege of serving as president of the UNC Health Foundation. And while I thought that our COVID-19 Game Changers series were going to be in our rearview mirror, unfortunately, here we are again today. We've got a packed agenda, lots and lots to cover with Dr. David Weber, who's been with us before. And I know you'll have lots of wonderful questions. I'd encourage you to continue to ask those in the Q&A or the chat. I know several questions have been submitted beforehand, and we'll try to get to as many as we possibly can. But I wanted you to know too that across the street from here, things are really challenging right now. Our One Great team is certainly leading the way, but this is not an easy time for our health system here in Chapel Hill and across the state, and quite frankly, across the nation. So I'm hopeful that what you'll hear today will be helpful, that you'll ask questions and engage with us along the way. And again, just enjoy the time with Dr. Weber. I want to start by introducing Dr. Christy Page, who serves as our Executive Dean of the School of Medicine, and she's going to get us started with today's talk. Dr. Page?
Thank you, Leslie, and thank you all for taking time to join us. Again, I'm Dr. Christy Page, Executive Dean of the UNC School of Medicine, and I'm delighted to be here with Dr. David Weber. I believe most of you know him, but I'll share that he is our Charles Addison and Elizabeth Ann Sanders Distinguished Professor at the UNC School of Medicine, and is one of the leading infectious disease and infection prevention experts in the world. We have been just blessed and so fortunate to have him here at UNC as a leader, both in the global response to the COVID-19 pandemic, as well as in guiding our university response over the last 18 months. As Dr. Burks has done during our previous Game Changer sessions, I'd like to offer just a brief update on the current state of our COVID-19 situation across UNC Health. As Leslie indicated, we are in a very difficult place at the moment. Since mid-July, we've seen a very rapid rise in our hospitalizations across the state as a result of the Delta variant. And the numbers have been hanging around about 450 hospitalized patients over the last few days and have leveled off some, which is good. But we're still in a place very similar to where we were in our peak in January. Except it is important to underscore that more than 90% of the hospitalized patients are unvaccinated, with 98% of those on a ventilator being patients who are unvaccinated. So that is especially sad to us. All of our hospitals are distressed, all of them, but with Southeastern, Johnston, Onslow, and Rockingham particularly stressed. But thanks to the work of Dr. Weber and others, we do know a great deal more about the virus than we did last year. The complication now is that many of our teams are strained and very short-staffed. We're doing all we can to support our teammates across the state, but there's a great deal of fatigue and exhaustion amongst our people. The emergency departments and the ICUs are flooded, and it's truly a hard time. So if you get a chance to encourage anyone in healthcare, please do. I want to thank you for what you've already done to support and to engage with us as we work together. I also ask, please keep doing all the things you can to stay safe. If you have friends or family members who have not received the vaccine, please encourage them to do so. It's just so important. I've also been telling my personal family members to drive safely and do all you can to stay well and healthy and out of the hospital for non-COVID reasons. And so I say that to you, my Carolina family as well, to please do all you can to stay safe and healthy and out of the need of the hospital if you can. With that, I'll turn it over to Dr. Weber. And Dr. Weber, before you launch into your COVID update, tell us and tell the group how you're doing personally with the endurance required over the last 18 months.
Well, certainly this is a marathon, not a sprint, and we all knew this when it started. I did not envision we would see such a prolonged pandemic, and one that would have such multiple waves. That said, I'm very proud of the excellent mitigation efforts that we have used to really have kept our healthcare colleagues and friends really safe. We have very, very limited transmission in the hospital to healthcare providers, and what there is really from being in break rooms, not from direct patient care. We knew how to protect our colleagues, and we did so. We knew what we had to do for our patients, and we're able to do that. Certainly the academic and scientific community, and I would say, as the Gates Foundation did, UNC is the leading research foundation, research authority on COVID in the United States. It's really stepped up. We rapidly develop vaccines. We develop therapies like monoclonal therapies. It's led to a horrendous toll of human lives. But the part we don't hear is the thousands of people we've helped. Just as one example, Dr. John Barada has now seen in his post-COVID care clinic more than 450 long haulers, and they're busy expanding that clinic capacity as just one of the ways UNC Healthcare is stepped up to help the community.
Great. Well, thank you for sharing that. We wish you well personally, as we know that you just worked an unbelievable number of hours and just poured your whole heart and all those years of expertise into being part of the solution. We're so proud of you, Dr. Weber. And if you'd like to launch into the first part of your update for us, we would love that. I learn something new every time.
Thank you very much for those kind words, and I'm happy to provide this update. Thank you very much. So I'm going to really talk about SARS-CoV-2, a constantly evolving threat, new challenges, but also new mitigation strategies. Could I have the first slide, please? So we're going to start off and talk about epidemiology. Next slide. So this is the most recent data, already just a couple of days old. You can see here, we're in really the fourth wave or surge. The 7-day average now is about 160,000 cases a day, not quite where we were back in January, February, but still increasing, although you'll notice the rise of increase is somewhat slower. The peak in the last 7 days, though, has approached the peak we had in January, February at about 280,000. If you look at our immunizations, we're about 53% immunized, 12 and above people eligible, only 62%, 65 and above people perceiving themselves at more risk, which is true 82%. This is really unfortunately low when you realize the country has now 95% of the country or more is immunized against measles. And this is a major issue, vaccine hesitancy and resistance to protecting people, as well as eliminating or dealing with this pandemic. Next slide. I just want to show you some of the impacts of COVID in the United States. We expect that by December 1st, unfortunately, 750,000 Americans will have perished from COVID, both in August as well as all of 2018. COVID is the third leading cause of death in the United States, surpassed only by heart disease and cancer. But I do want to show you the dramatic impact in decreasing the life expectancy of people at birth and decreasing the life expectancy at age 65. Also, and probably also even more dramatically, as the impact COVID has had on our disproportionate impact on the Latino and Black community. I should say, if a member of those communities is sick enough to come into the hospital, once you adjust for age and comorbidities, they have the exact same mortality of any other patient. So these are disparities that exist to many factors in life, such as exposure, access to healthcare, and others. But this is only one of the major, just another view of the major impact COVID has had on the historically, on these disproportionate on these communities. Next slide. What's happening at UNC in the upper left? This is from data from my colleague Lauren DiBiase here. You can see after we hit a low point in May and June, the number of cases, floor cases and ICU admissions has increased. On the right, you can see along with that increase, the number of tests and positive tests has increased. And you can see we've gone from maybe 2-3% of symptomatic people testing positive and less than 1% of asymptomatic. We're up in the 10 to 15% range for symptomatic people testing positive, and in the 3 to 4% range for asymptomatic people testing positive. Next slide. Oh, go to the next one. Okay, we'll talk about variants and vaccines next. Thank you. So this is what's driving the pandemic. You can see this explosive rise of the Delta variant, slight mutations in the spike protein of SARS-CoV-2. You're going back to May and June, just this explosive rise, which is now continued, where the Delta variant is just dominating all the variants in the US. Even more impressive is the rise we had at UNC. You can see in purple going from virtually no Delta in just a few weeks to a dramatic increase. And now, as with the country, virtually all our strains are Delta variant. This is because of increased transmissibility. I'll talk more about that. It clearly has increased virulence. I'll show you that in a minute. Somewhat decreased protection from symptomatic vaccines have somewhat decreased protection against symptomatic infection, but good protection against severe disease. We've eliminated mask mandates in many locales, although, for instance, you can freely go to restaurants now and across the state, although we have reintroduced mask mandates in K through 12 schools. Ongoing vaccine hesitancy and resistance, holidays, including now Memorial Day and fall activities, breakthrough disease and fully vaccinated people playing a role, but a small role, and several studies all showing that this variant is about twice as likely to lead to hospitalizations or severe disease. I didn't put it here. The Mu variant is also of concern, only represents about 0.1% of cases, not as transmissible as Delta, no evidence it's more virulent, but some evidence that it also escapes from monoclonal antibodies and vaccines. Next slide. I just want to show you again just examples of why we're seeing Delta transmission. This was one outbreak where they sampled individuals who had Delta. One, you can see that the index case there, this was super spreading events, one person infecting many people. The viral loads are about more than 3 logs higher. This is why it's more infectious, because you have tremendously more amount of virus, and why people who have not been vaccinated, vaccine does lead to quick clearance of the virus, are likely so much more ill. Next slide. So if you go back to the ancestral strains of SARS-CoV-2, the initial SARS, flu, Spanish flu, the row, meaning if I'm infected, how many people do I infect on average, was about 2 to 3. The new strains, the Delta variant, is somewhere between 5 and 8, very similar to chickenpox and mumps. Less certainly than measles, but this is just another way of looking at how much more infectious the Delta variant is. Next slide. So let's talk a little bit about vaccines now. The current state of vaccines, one of our major mitigation effort here. The Pfizer vaccine is now FDA approved for ages 16 and over. They have full approval, having met all the requirements for safety and effectiveness. Third dose of Pfizer has an emergency use authorization, as does Moderna. For Pfizer for younger people, Moderna for older people, as a third dose for people with moderate to severe immunocompromise, and we are using it that way. But currently there are no changes in the FDA authorization or CDC recommendations for J&J vaccine. Just in the last few weeks, the Centers for Disease Control and professional societies, such as the American College of Obstetrics and Gynecology, have a much more strong statement recommending COVID vaccine for pregnant women. They now explicitly say that all pregnant women should receive this vaccine, that benefits greatly exceed any possible harms, and that harms have not been demonstrated. In the next 2 weeks, we will see the CDC first with Pfizer and then with some lag with Moderna vaccine, considering booster doses for non-immunocompromised people, and I fully expect that to be approved. Vaccines for younger children, 11 and below, CDC or FDA has asked for somewhat larger studies because of concerns about myocarditis and pericarditis. So I don't expect approval until late fall. For the youngest children, 6 months to say 3 to 5, I don't expect a review by the FDA until late spring. And again, I want to know these vaccines are still highly effective in preventing serious disease from Delta. Next slide. Again, here is some of that data. You can see the decreased vaccine effectiveness in the right, the pre-Delta to Delta era. It's hard to disentangle how much of this change is due to Delta and how much may be waning of immunity over time, people having begun vaccines back in December. But again, on the left panels, you'll see the vaccines still are extraordinarily protective against hospitalizations and severe disease. Next slide. So I want to show you some actual data from the hospital here. This is over the last few months, and again, prepared by our excellent individuals here working in infection prevention. Roughly 85% of our COVID floor admissions there have occurred are occurring in unvaccinated people. 95% of the people we have had in the hospital and the medical center who made it to the ICU were unvaccinated, and 100% of the people dying were unvaccinated. What's more, of those small numbers of vaccinated people sick enough to come into the hospital, 2/3 were on cancer chemotherapy, had a solid organ transplant like a kidney, or on high-dose steroids, all known immunocompromising states, which we know decreases the effectiveness of vaccine. And this is not a complete list of immunocompromising states. I think if we broaden this list out, you would find the great majority of people sick enough to be in the hospital were unvaccinated. Next slide. So I was honored to be the lead author now back in July of this multi-society position statement. You can see it included a number of societies recommending that vaccine be a condition required as a condition of employment in hospitals. These societies represented about 35,000 healthcare professionals. I don't have a slide because it happened yesterday. You're all aware that the Biden administration has extended requirements for COVID vaccine now to any hospital or facility that receives Medicare, Medicaid funds, employers over 100 individuals, federal employees and contractors. So this idea of expanding requirements for vaccine has only spread since July. Next slide. And just to show you many of the hospitals, including UNC, and virtually certainly every major chain system in North Carolina, and virtually every hospital has also agreed to make a vaccine a requirement of employment. We do accept medical contraindications and religious objections. So as you can see, we're well positioned to adhere to the new requirements from Dr. Biden, from the President Biden. Thank you. Next slide. Again, the basis for the multi-society guideline are that the vaccines are safe and effective. First of all, our first goal, of course, is we protect patients by protecting our healthcare personnel. We provide them individual protection there. We certainly help protect our patients who cannot mount adequate immune responses, reduce the risk of asymptomatic or pre-symptomatic transmission. We screen all of our healthcare personnel, our patients and our visitors when they come into the hospital, and patients and healthcare providers every day for symptoms of COVID. But 40% of people can be asymptomatic with infection, and they could transmit it. We reduce the risk of transmitting infection to household members and community contacts who can't receive vaccine in 11 and under or immunocompromised. And we also make a positive statement for the public that we as healthcare providers believe vaccines are the right way to go, and that's why we're requiring them to help deal with vaccine hesitancy. Next slide. Now, in terms of the immunocompromised individuals, they're more likely to get severe disease. They have a higher proportion of infection, lower antibody titers to vaccine, more likely to transmit disease. And you can see that vaccine effectiveness among immunocompromised is substantially lower than it is against healthy individuals. This has led to studies about trying to improve that with a third dose of vaccine, usually administered 6 months after their second dose of an mRNA vaccine. Next slide. And what we showed for them was that a great number of them either developed antibodies where they didn't have them, and when they did develop antibodies, at a much higher titer. Now we're going to be rolling out the booster shots for the general public. There are new studies from Israel showing already that it is effective in preventing infection. They'll phase it in by date, so You probably have to be 8 months since your initial vaccine series was completed. So, of course, healthcare providers and long-term care residents were the first to receive vaccine back in December and January, and therefore would become the first to be able to receive vaccine booster shots. And of course, we do plan to provide these through our occupational health department to our healthcare personnel. And we're already providing the booster shots to our immunocompromised patients through our clinics. Next slide. I just want to show you this one very impressive early study coming out of Israel. There are other studies. What they found is just 12 days or more after a booster dose, very short period of time, there was roughly a 12-fold decrease in the relative risk of infection, a greater than 10-fold decrease in the relative risk of severe illness, and under a conservative sensitivity analysis, at least a 5-fold protection even against confirmed infection, meaning if not infected, then you actually can't transmit disease, which will help us deal with this current surge. And I would fully expect that when they look at those individuals a month after receiving a booster, it would show that it's even more effective than you are seeing here. And this is what will almost certainly lead to the FDA providing an EUA for booster shots in the next 2 weeks. Next slide. So I just will come back and talk about some additional topics, but I'm happy to answer any of your questions.
Sure. Dr. Weber, thank you. This is great. We have a number of questions and certainly some in the chat that we'll get to, but can we stay with boosters for just a second? And we had a lot of questions around booster shots. I know it's really hard, you don't have a crystal ball, but do you have any sense as to when the boosters might become available starting in those phases that you just showed? I know you said maybe 2 weeks longer for authorization, but then past that, can you speculate?
I would guess that at their meeting, which I think is now scheduled for the 17th for the FDA, if not, it'll be sometime by mid next week, the FDA will authorize a booster. The CDC will meet the day after the FDA, or potentially even in the afternoon after the FDA. It will be approved by them. We'll have to see if they have any more guidelines than just wait either 6 or 8 months. And so I think it'll happen very quickly. I should say there is no shortages of vaccine. And of course, in addition to a vaccine being administered by individual clinics, and they're available in many pharmacies, Walgreens, CVS, and others. And I've heard from my patients and others, you can go on the web and just click on it and receive a vaccine the next day. There might be a little slowness as they unroll the first week or two, but I envision that anybody who wants a booster, and I certainly encourage anyone who's eligible for a booster to get it, that they should be able to receive it within a week of it becoming released through their own healthcare provider or through one of the pharmacies.
Dr. Webb, go ahead. Sure. I just wanted to jump in with another question we had is there harm if a patient goes to CVS and gets it earlier than 8 months?
So no, there is no harm. And I think certainly there's nothing magical about the 8 months. We're doing it at 6 months for immunocompromised individuals. I will say technically they need to do it off-label, meaning when you go to CVS, it's going to ask you if you're immunocompromised, and you have to attest that it is. The disadvantage for somebody doing that potentially would be if they had a side effect. They might be ineligible to receive compensation from the federal compensation program since they're not adhering to the emergency use authorization. So my recommendation is just go ahead and wait the 2 weeks, which it'll all be before the vaccine is officially released. I don't envision there will be any vaccine shortages, or that there will be such a backup at pharmacies and others that one would have to wait weeks to receive a vaccine. You might have to travel a little bit, maybe not get it at your nearest pharmacy, but I don't think you'll have to travel very far.
So again, sticking with the booster topic, will the boosters be changed in any way from what we all got earlier in the spring, late winter?
So that's a very good question. The Pfizer one will become available first, with the Moderna one a couple of weeks later because they were a little slow getting their paperwork in. The Pfizer vaccine will be identical. It's my understanding that the Moderna vaccine will likely have about half the antigen content that the original vaccine had, but they also started with the much higher antigen content than Pfizer. So I don't think that will affect its effectiveness, and I'm sure it's based on, if that's what's approved, based on still being highly effective and giving an antibody response and maybe somewhat less side effects. The unfortunate thing is at the moment there is no data on the J&J vaccine for the FDA to act on to recommend either a second dose of that vaccine or boosters using one of the mRNA vaccines. Certainly something that needs a rapid, fast study and then a review by the FDA and the ACIP.
Dr. Weber, sticking with vaccinations, but more broad, not just about the booster. You talked about the recommendation and the clarity that our organizations have that vaccines are recommended in pregnant patients because of how sick patients can get with COVID in pregnancy. There's still concern or hesitancy for vaccines related to fertility and concerns that it has any impact on that. Could you please speak to that? Does the vaccine have any impact on fertility?
So first, there is no rational reason to believe it would. None of our vaccines that we have in the United States that have been approved have any effect on fertility. There's no reason to believe this vaccine wouldn't. The mRNA does not enter the nucleus of the cell. There have been studies, for instance, on fertility in men showing no harm on sperm counts or sperm motility. There's just no evidence to support that. And I've mentioned two professional societies, all of whose members are totally devoted to good care for their female patients, the American College of Obstetrics and Gynecology and Society for Maternal Medicine and Maternal Medicine, have both agreed that there is no effects on fertility and women should get the vaccine. I would also say there is nothing that provides more harm to a fetus than a sick mother. Mm-hmm. And we actually have enough pregnant women that we actually have a COVID unit within obstetrics and gynecology. Many of those women, because pregnancy does have some negative impacts on immune status, have done very poorly, requiring long stays in the ICU and even ECMO. So the best way I would tell women to protect their unborn child is to get vaccinated first, to protect the child as well as to protect themselves. And there have been now tens of thousands of women pregnant who have been studied and no harms have been demonstrated in them. And this, by the way, becomes only the third vaccine that CDC explicitly recommends for pregnant women. The other two being flu vaccine. We're getting close to flu season and flu vaccines are now available and pregnant women should get that. And then the other one is the Tdap pertussis vaccine, which is not to protect the pregnant women, but to protect their young infants from pertussis. And those represent the only three vaccines explicitly recommended for pregnant women, although most other vaccines are safe and should be used as indicated.
Thank you.
So we'll stay with this topic a little bit longer and just ask, do you think that healthcare professionals or the general population will have to get boosters every 8 months? Or what does the long haul look like in terms of the cycle of when we'll be required to get immunized?
I think if we can end up immunizing the great majority of the United States and then help with immunizing the rest of the world, then SARS-CoV-2 is not going away. It'll become endemic. We will continue to have small numbers of cases. In general, coronavirus, and we have 4 endemic coronaviruses, mutate about the third the frequency of flu. So I don't envision we'll need yearly shots. We may need periodic shots like we do with tetanus diphtheria. I will say I find it both distressing as being someone in public health and irritating to see that the United States, which we started early with our vaccine, so back in December, January, we're in the top 3 countries in terms of coverage. Depending how you count countries now, do you consider Gibraltar a country? We rank somewhere in the world between 40th and 60th in our vaccine coverage of the United States. So if you looked at the top 15 countries in the US, you would find that they're roughly 75% or more of their population is immunized. I just told you the US is at 53%. So you have countries like, Chile and Hungary and Qatar and mainland China as just examples who have immunized substantially larger parts of their population than the US. So this is not only an individual choice issue. This is a public health issue. By choosing not to be immunized, not only are you putting your life at risk, and I already showed you all that data, you're putting your contacts and your loved ones at risk, and you're putting everyone else in the community at risk. And if we had had this type of vaccine hesitancy, 50, 70 years ago, we'd still be facing polio with 20,000 children having paralytic polio every year in the United States, filling up our hospitals at this time of the year. Thousands of people dying of measles and dealing with that. And we would not have eradicated smallpox. So this is having a major impact, vaccine hesitancy and resistance on people protecting themselves and protecting the community.
So one last question, and then we'll move on to the rest of your slides and we'll come back to the questions. Are the vaccines interchangeable? So we've got a lot of questions in the chat about, if you receive the J&J vaccine, can you have the Pfizer booster or Moderna, same thing? Are they interchangeable?
So with regard to the two mRNA vaccines, Pfizer and Moderna, the FDA and the CDC say, in general, when you're ready for your booster or third dose, you should get the same vaccine. If the vaccine's not available, and here they're really talking about a shortage, not meaning that, CVS says, well, we ran out of it at 4, but come back tomorrow, then it's okay to get the other mRNA vaccine. But there are currently no recommendations for somebody who had J&J to receive an mRNA vaccine because there's just no scientific basis to know if it's safe and effective. There are actually people who have hypothesized that by getting two totally different type of vaccines, an mRNA and the J&J, which is an adenovirus-based vaccine, you might actually get even superior immunity, but that remains to be shown in a clinical trial.
Thank you for allowing us the opportunity to get to some of these questions. We'll get started with the second half of your slides and then come back.
Good. Thank you very much. I want to talk to you about a whole series of some other issues. Next slide, please. So here's what's happening with vaccines. We're up at 4 million doses a day. We dipped down to less than 500,000. You can see a slow rise since July. That's led by two factors, really. The first being allowing the vaccine for 12 to 17-year-olds, counted for some of that. And the other, of course, is the widespread transmission of Delta, with people increasingly being concerned about hospitalizations and deaths from Delta. But again, only a little over the 50% of the total US population is immunized. So we'd love to see those numbers go back into the millions each day. Next slide. If you look at vaccine unvaccinated adults and wait and see, definitely not get the vaccine. One you really can't see on this slide, but if you looked at things over time, you would see that the wait and see people have gone from about 50% to maybe 10% to 15%. That's decreased if we've gotten more data on safety and effectiveness. The truly vaccine resistant group who say, I'm not getting the vaccine unless it's required, still hover in the 15 to 25% range. That has not changed since December, despite all the new data. You can see people in terms of getting vaccine, it varies tremendously by age. It varies by race, ethnicity, by party affiliation, education, income, and a variety of other factors as well. So this means when we deal with vaccine hesitancy, there's not a one-size-fits-all solution. We have to deal with each individual patient population who is hesitant in a different way. Next slide. This was a very nice paper. I encourage all of you to read in the New England Journal. In the New York Times. And you can see they broke people down into the watchful waiting. Many of those are now convinced to get the vaccine. The cost conscious, we need to emphasize, vaccines free. But I should say many people, even if the vaccine's free, there is an opportunity cost. They have to miss work to get the vaccine, or there aren't vaccine centers near them. UNC does have a mobile vaccine van that's been used to bring it to communities. Pushing vaccine out to local pharmacies, certainly helpful. And of course, as part of Biden's current plan is the requirement, which is already in place, by the way, for healthcare, that employers give people time off and pay them to get the vaccine. You have the system distrusters and the vaccine skeptics. There you have to get people for the distrusters, and certainly a number of the disadvantaged communities have ample reason to be distrusters. You need to engage trusted members of their own communities. And for the COVID skeptics, trying to debunk their myths is not going to work well. You have to emphasize to them not only the importance to their health to get vaccinated, but appeal to their desire to protect their children, their grandchildren, and their loved ones. Next slide. So this all has to be individualized. Let's talk a little bit about mitigation strategies here. The things that we've developed and we know work, vaccines, I've talked about that. Universal pandemic precautions, wearing masks, screening people coming into the hospital, physical distancing, the monoclonal antibodies all work. And then the things we do for other infectious diseases that work as well. Hand hygiene, surface disinfection, contact tracing with isolation and quarantine, and wellness self-checks are all things that we encourage as COVID mitigation strategies, but we use them for measles and flu and RSV and many other infectious diseases as well. Next slide. So I just want to show you, this is some work. This is from Mike Cohen, former division chief here, and ID, still here, still active, and is director of our infectious disease center. And here they looked at one of the monoclonal antibodies, bamlanivimab, BAM, and they showed this was in a nursing home, that using a pre and post exposure when there was cases in a nursing home compared to placebo had a dramatic decrease in the number of people becoming ill. So demonstrating pre and post exposure prophylaxis in a congregate setting like a nursing home potentially could help in others, such as jails and even college dorms. So far, it's only FDA authorized for post-exposure prophylaxis, but certainly we would hope it'll get authorized for pre-exposure prophylaxis. And to date here across the UNC Health, we've treated more than 4,000 patients with this drug for treatment or for post-exposure prophylaxis. Next slide. Dr. Cohen was also a member of this study, although not the lead author. This just came out recently. This is for post-exposure prophylaxis, meaning someone in the family has COVID, or you go to a wedding and they call you back 3 days later and say somebody tested positive who was seated at your table. And you can see here, and this is authorized for vaccinated people who are been immunocompromised, and unvaccinated people are at high risk of progressing disease. You can see that it reduced the risks of developing infection 80% and symptomatic disease by 90%. And you can look at how dramatic it was, the red versus the blue, for duration of symptoms in those that got sick. So this really ameliorates the disease. We do offer post-exposure prophylaxis here through our infusion centers, although it can be given both by IV infusion and sub-Q administration. So it could be used potentially given by like home health just with subcutaneous injections. Again, one of the few bright spots, along with booster shots, and how we're helping mitigate and improve, decrease the risk of patients and improve their outcomes and decrease infections, and how also UNC is a leader in this type of research. Next slide. What about, I'm sure many of you have questions about school. I should say Duke and UNC, we do fight on the basketball court, but we don't fight when it comes in terms of research and public health. So Duke and UNC are part of the ABC Collaborative. I'm a member of that collaborative, which is NIH supported, to look at and prevent transmission in schools in North Carolina. This is all work before we had vaccines. The primary way of preventing infection are masking and physical distancing. And you can see from this data the rates in the counties in North Carolina and the bars at top, and then the rates in the schools that we were using mitigation strategies are substantially lower than the rates in the community. Now, we're not going to be able to make schools risk-free, but I'm going to show you in a minute, most of the students in those K through 12 schools who get sick are getting it not in the school, they're overwhelmingly getting it in the community. So we can send people safely back to school, and mitigation works, and vaccines will only help in the future, or help more. Next slide. So this is our more recent paper. Again, Dr. Zimmerman at Duke, Kenesha is the lead author. Look at the graph on the right. So at the top in the dark bar is the community rate from North Carolina counties. And this was done over the surge in the December to February time period. And those little bright red dots, those are primary cases that occurred in the schools where people got it in the community. The first thing you'll notice, people do believe in protecting their children. And so the rates of younger individuals were lower than the rates in the community, in part because they're not going to bars and large indoor meetings and so on. But look at those little blue dots all the way at the bottom of that. That's the secondary rates. Those are transmissions within the school. So for every 20 primary cases not acquired in the school, there was only one secondary case. So we showed again that the mitigation strategies led by the ABC Science Collaborative here in North Carolina dramatically protect our students. However, one little spot of concern down in the lower right, if you look at pre-surge and surge, you would actually see that post-surge, the rates continue to fall in the K through 12 schools. But if you look at that middle column and then to the right, you would see the rate post-surge in the high schools was almost 4. But if you take out sports, it goes down to 1. So, and there was just a recent article, CNN, Washington Post had it too, that what's driving the rates in K through 12 schools in North Carolina and across the United States really are contact sports where people are not physically distanced and not able to wear masks. So there are a lot of potential ways of dealing with that. One would be to make as a condition of participating in a sport that they receive vaccine. That is allowable because you're not prohibiting anyone from going to school that way, although California now requires all students who are going to school to be immunized. A second option would be frequent testing of those individuals, potentially, but vaccine would be more successful. But that does is a recognized risk in K through 12 schools. Next slide. What about mental health issues and public health individuals? Just a paper here in the United States, 26,000 respondents, 56 reported one mental health condition, depression, anxiety, PTSD, suicidal implementation. The now almost 2-year-old pandemic has had a tremendous impact on the mental health of healthcare providers and public health workers. This has been a very long marathon. They're on the front lines every day. We're understaffed for the number of people who are asking for care, both COVID and non-COVID individuals. Although we do an excellent job of protecting them, it is enormously stressful to be taking care of these patients and worrying that if you slip up with your personal protective equipment, you may be putting yourself at risk, working long hours, dealing with the now 650,000 deaths in COVID and soon to be 750,000 deaths has really felt a tremendous amount of stress. I should say, by the way, we just received some data, not yet published, where we've surveyed our people here at the medical center, and overwhelmingly, one, they do believe the medical center has responded to their needs, and two, that the mitigation strategies we use at the medical center protect them. Next slide, please. And this is just a systematic review I did with some colleagues from Thailand to show you that the concerns in the United States are mimicked all over the world in our healthcare providers. Depression, anxiety, insomnia And fear, well, we don't particularly have fear about that our mitigation strategies won't work. Many other places, unless the developed countries, don't have access to vaccines or much lower, don't have access to the personal protective equipment we use. So this is a concerning issue for the entire world, not just for the United States. Next slide. I do want to point out to you, just in terms of impact here of and where going in the future, you can see here right now, COVID, a slide I put together, about 640,000 deaths, surpassing the number of soldiers we lost World War I, World War II, dwarfing 9/11 as we get close to that tomorrow. But by the end of by the beginning of December, and the latest data, actually, the slide needs to be updated to 750,000 more people will have died in the United States only from COVID than died of HIV in the AIDS pandemic or in the 1918 flu. Next slide. So what did we not do well from a recent paper that we published? Well, we've not had a really centralized, coordinated federal response. The executive branch, at least initially, consistently minimized and trivialized COVID. Our public health structure is inadequate, slow development and scale up of testing, inaccurate initial assumptions about transmission. They're inadequate stockpiles. In the initial, we didn't realize the importance of asymptomatic transmission. We didn't initially recommend masking by the public, which led to confusion, and still today says is one of the reasons people don't want to wear masks, saying, well, you told us not to initially, and initial failure to look at the transmission in nursing homes. Ongoing pandemic concerns are science denialism, politicization of pandemic response. I told you about vaccine hesitancy and resistance, lack of vaccine so far for children, new variants like Delta, post-COVID clinical care issues. So even if this magically ended at the end of this year, we're going to have millions of people with post-COVID care syndromes requiring care for months or years in the future. Up to 30% of people with COVID have ongoing symptoms that last at least 6 to 9 months. Lack of public health support for public health intervention. Hundreds of public health workers around the country have left the job, either because of the stress I told you about, or because in many cases, actual threats from members of the public as they just try and implement measures to protect the public. We'll see if we need recurring boosters. We talked about that. Even though this is the latest information I'm giving you, there will be unanticipated challenges in the next 6 months. And finally, all of us are suffering from pandemic fatigue. I think that's probably my last slide, except for this one. I certainly want to thank all of my colleagues here throughout the medical center at every capacity in the medical center, because this is really a team effort. They're all heroes. They put their lives and health on the line every day. They've made tremendous sacrifices. And of course, we need to be very thankful for all of them.
Thank you, Dr. Weber. If you have questions, please do put them in the chat. The one that's come across, I have a couple for you, Dr. Weber. But you talked about schools and school safety. And as you know, it's a major point of stress and anxiety for our parents and grandparents to send the children who are too young to be vaccinated to school. What do you recommend to parents as the best way to keep children safe and in school?
Well, the first is all but 3 counties in North Carolina, despite the fact there isn't a statewide mandate, now are mandating masks in K through 12 schools. That is the single most important thing we can do. Equally important is when they, a student, and of course, teachers need to be masked, staff as well, not just the students. The second thing we need to do is physical distancing, particularly when students can't be masked, eating and drinking, and that can be handled by eating outdoors, temperature, if the weather permits, or by spacing out eating in smaller times, 15-minute intervals, and then staggering how they eat, and that's been done successfully. Finally, of course, vaccines. Every child 12 and above should be immunized, every teacher and all staff members. And we are seeing school systems, just as healthcare systems, are mandating masks as a requirement of employment. And now we've seen California requirement for students. So those are the 3 most important. The next is self-wellness checks among everyone. Certainly, if you're sick, stay home, stay home, stay home. Don't go to work and don't send your kids to school if they're sick. Call your healthcare provider and get them tested. I should say not only is COVID obviously being a major issue now, but RSV is just running rampant in the community, and it's a major strain adding to COVID in our pediatric intensive care unit and on our pediatric floors. So stay home. This working while you're ill has a term by itself called presenteeism, and we do see that not only in healthcare, but across the work spectrum. And then finally, we need to deal with how best to prevent transmission in athletic teams. And it's not every athletic team, something like diving, where only one person's in the pool at a time is really not the risk. It's things like football and basketball. And so we need to think about strategies such as requiring immunization for them and potentially very frequent testing. But I will tell you, very frequent testing is not a prevention strategy. It's an early mitigation strategy for case detection and limiting the transmission, but it's not a prevention strategy like masking or vaccines. And we do have to balance risks and benefits, and clearly children need to go to school. They need the socialization skills at every level from kindergarten right up through college. They need to learn how to work well and deal with others. And then there are just some things you really can't learn in a remote program. In a college, we can't teach chemistry remotely, and you really can't teach a child how to work with another child and do a jigsaw puzzle together. So the benefits of school are obvious. They've been described many, many times. And so we have to learn to deal with COVID and how to do it successfully.
Thank you.
So if we could just stick with kids for just a second, what is the hesitancy to approving the vaccine for kids 12 and under?
So there's no question that the vaccine ultimately, I think, will demonstrate to work. Kids actually have better vaccine responses. So really, the biggest issue is in a small person, you don't want to give them as much antigen. That's what you put in the vaccine that we get an immune response to in a young child. So there's a difference between immunizing an adult at 140 pounds versus a child who's 6 months of age and weighs 12 pounds. So you have to do studies to decide what the optimal amount of antigen is. In general, more antigen is better. You get more antibodies, although if you keep increasing the antigen, you don't keep getting more antibodies. At some point, you get a plateau. So you have to find that sweet spot. Plus, the more antigen you put in, the more side effects you get. Things like arm pain, redness, tenderness, and fever. So it's always a balance between finding the right amount of antigen and for effectiveness and safety. That's what's really slowing it up, is making those determinations in children. The other thing, and Delta may change this, is the risk-benefit ratio is different. We've already seen the horrendous toll that COVID has taken on people over 65. And this disease has the biggest age-related differences in mortality of any infectious disease. So if you're 50 compared to age 20, you have a 100-fold higher risk of death. If you're 100 compared to 50, you have another 100-fold risk of death. I mean, you have a 10,000 difference between age 20 and 100. Even things like having a 10,000-fold difference, even having things like having an organ transplant or being a bone marrow patient, those carry risks of like, 10-fold. So this dwarfs that. So it's easy to say, even if there were substantial side effects or we didn't know duration, we needed to immunize older people. The younger children, even though they now account for 20% of hospitalizations, still are relatively, and I say just relatively, well protected against getting severely ill, because we do have 2 young children on ventilators here in the hospital now. But not, so the risk-benefit ratio is different. So one, you have to reformulate the vaccines. You have to test safety and effectiveness. And then you have to look at the risk-benefit ratio, which is different in younger individuals. That's what's slowing them up. And they have, in the interest of speed, broken them up in time. So they're doing the somewhat older individuals first, and then the youngest there. I should say there has been no problem in recruiting people. Mothers and dad wants their kids immunized. And so it's been quite easy for the centers that are doing these trials to recruit children. That's not what's slowing it up. It's not problems from the drug companies. It's just getting that data takes some time, and they wanted to have the data in adults first.
Thank you. Thank you. Another question that came in is about the Biden administration's mandate announcements yesterday. And the question is, are qualifying businesses, meaning those over 100 employees, required to have employees vaccinated? Or is there a, unless the employees receive weekly testing? And there's some other questions about the value of rapid testing in asymptomatic patients. Maybe you could touch on both.
Sure. So of course, none of us have actually seen the plan, and I'm almost sure it will include medical contraindications and religious objections. And then the question is, what's reasonable for the unvaccinated who either have a religious objection or a medical contraindication? And many people have proposed and recommended frequent testing in that group. We are doing it among our students here at UNC. Again, it's not a prevention strategy, but it's an early detection strategy since they have a tremendously higher risk of infection. One, if they're asymptomatic, you would send them home during their infectious period, 10 days. And two, then you would carefully question them with contact tracing. So if they had exposure, if they exposed other people, you could go test them of limiting the amount of transmission. Now, antigen testing is neither as sensitive or specific as the PCR testing, but if you're using it very frequently, sports teams do it every single day. Many other places have been doing it, and that's not what we're using at the university. Ours is a PCR test. But if you're doing it because it's simple and much less expensive, if you're doing it 3 times a week like nursing homes have, well, if you miss somebody on Monday because it's not quite as sensitive, then you pick them up on Wednesday. So if you're going to be using antigen, you have to do it very frequently. Again, it's one, a carrot to people to getting their vaccine, and two, it does help limit spread, but it's not near as good as wearing a mask or getting vaccinated. Again, we'll have to see how this all rolls out and what the actual requirements are for the vaccine and what the timetable is and other issues.
So we're just about at time, Dr. Weber, but I think let's close with football if we can. And we have a big football game here on campus tomorrow. What are your recommendations around attending large events like a football game? And are you recommending wearing masks outside? Talk a little bit about that as we close out.
Certainly. So outdoor transmission is much less common than indoors, and that's because as opposed to indoors, when you give a cough, your spume of particles and is in a relatively small airspace and doesn't disperse. Outside, of course, infinite airspace, winds and movement of the air disperse things there. UV light kills the virus. So outdoor transmission, much less likely. That said, transmission clearly can occur outdoors. It's related to how long you're next to somebody, not wearing a mask there. And it makes perfect sense if you're sitting shoulder to shoulder in either a movie theater where someone wouldn't be masked, or at a bar, or for that matter, at a football stadium, if someone turns their head and they're infected and gives a good cough and your face is, a foot away, you have, a risk of getting infected. So the first thing is, if you're immunocompromised, watch the game on television. If you're unvaccinated, watch the game on television. If you are vaccinated and and particularly if you don't have people you're concerned about bringing disease home, young people or immunocompromised people, go to the game, but wear a mask. But there will be some risk there because even if you mandate masks, and they do plan to hand out masks, it's really hard if somebody's sitting in the middle of, row 30 takes off their mask in the middle of the row. How are you going to know about that, and what penalties are you going to do? So yes, there's some risk in those types of settings, and we all need to make our own independent risk assessments what to do. But vaccination and masking are good protections, but maybe not perfect, because if you're in the supermarket and somebody starts hacking and coughing and they took their mask off, you can just walk away from them. And if you're in the middle of the row with 10 people on either side, it's a little more difficult to escape.
Okay, thank you so much, Dr. Weber. So I just want to extend our gratitude to Dr. Page and Dr. Weber for taking this hour to update us on COVID-19. Wonderful presentation. I know we didn't cover absolutely every question. I can assure you we're going to continue on this COVID-19 Game Changer series. So if you didn't get your questions answered today, you can either feel free to reach out to us. I know Dr. Weber's offered to answer questions, or we can as well. So thank you so much for joining us. And the last thing I'll say is if you are interested in supporting the work that we're doing at UNC on COVID-19, I would encourage you to make a gift to the UNC Health Foundation. And we're putting up those links right here. And I think that's all for this afternoon. So again, thank you so much for being with us. We appreciate it. Have a good afternoon.